Hey everyone, and welcome. If you're a radiation oncology resident currently in training, you absolutely know the feeling. Keeping all these doses, trials, and guidelines straight can honestly feel like drinking from a fire hose. So today, we're jumping right into a high-yield thoracic explainer. My goal here is simple. We're going to cut through the noise. We'll distill down the absolute essential board-relevant data you need, not just for your exams, but for your day-to-day clinic decisions. Let's get right into it.
Here's our quick roadmap for today. We'll be covering non-small cell lung cancer, oligometastatic disease and recurrence, mesothelioma management, limited stage small cell, and finally, extensive stage and PCI. Starting off with Section 1, non-small cell lung cancer, specifically focusing on targeted and palliative care.
The evolution of ALK-positive targeted therapies is just incredible to look at. I mean, we went from Profile 1014 establishing crizotinib, right, through Ascend 4 with ceritinib, but then the CROWN trial happened, and it completely changed the game. Lorlatinib became the preferred first-line standard, and why? Because it delivered an unmatched 60% 5-year progression-free survival rate. Compare that to just 8% for crizotinib. Plus, it offers phenomenal central nervous system control. It is literally a monumental leap in systemic efficacy.
Now, another massive shift in non-small cell comes from the Keynote 189 trial, a real practice changer. They found that adding the immunotherapy drug pembrolizumab to a platinum and pemetrexed chemotherapy backbone effectively halved the risk of death compared to just doing chemo alone. The big takeaway here? This survival benefit, where 1-year overall survival jumped from 49.4% up to 69.2%, was seen regardless of the patient's PD-L1 expression levels. It fundamentally rewrote the standard of care for metastatic non-squamous NSCLC.
Okay, picture this. You're on the clinic floor, evaluating a patient for palliation. You definitely need to remember the Sundstrom trial from 2004. Giving 2 massive 8.5 gray fractions, which totals 17 gray over just 2 days, spaced 1 week apart, actually provides equivalent symptom relief, quality of life, and overall survival compared to a much longer 42 gray and 15 fraction course. It's such a practical, low-burden option for your patients who aren't candidates for curative intent.
Moving on to Section 2, oligometastatic disease and recurrence. We're going to look closely at aggressive local therapy.
You will definitely, for sure, be tested on the Gomez trial, so let's unpack it a bit. They took patients with 3 or fewer metastatic lesions who hadn't progressed after their initial systemic therapy and randomized them to either local consolidative therapy, think surgery or SBRT to all sites, or standard maintenance. The results? Local consolidative therapy dramatically extended both progression-free survival, jumping from 4.4 to 14.2 months, and overall survival going from 17 months to over 41 months. It is a striking validation for stepping in aggressively with local intervention in oligometastatic patients.
Treat these diagnostic criteria like a mental flashcard, guys. We all know distinguishing radiation fibrosis from an actual local recurrence after SBRT is notoriously tricky. But if you're looking at a CT and you see 3 or more high-risk features, maybe a bulging margin, loss of an air bronchogram, or sequential craniocaudal growth, or if you see a persistently high PET SUV without a relative reduction of at least 5% after a year, well, that is highly suspicious for local recurrence. These specific imaging cutoffs are absolutely your best diagnostic tools here.
Interestingly enough, we're even seeing device approvals entering our domain now, thanks to the LUNAR trial. This trial actually showed a clear overall survival benefit, 13.2 months versus 9.9 months, when adding tumor-treating fields to standard systemic therapy in metastatic NSCLC. And what's really notable is that the largest benefit was seen in the subgroup getting immune checkpoint inhibitors. It's a fascinating, low-toxicity addition to our clinical toolkit.
All right, Section 3, mesothelioma management. Let's dive into some of the technical challenges.
Here's your high-yield systemic summary for mesothelioma. We progressed from the EMPhASIS trial establishing cisplatin and pemetrexed over to MAPS, which added bevacizumab. But you really need to pay special attention to CheckMate 743. That's the trial that brought FDA approval to the immunotherapy combo of nivolumab and ipilimumab, demonstrating a really durable survival benefit, especially for non-epithelioid histologies. You have to understand the shifting systemic backbone so you know exactly when and how to integrate your radiation.
Now, when you're called upon to simulate a classic radical hemithoracic radiation technique, you absolutely must follow these sequential organ blocking and shielding steps meticulously to avoid fatal toxicities. Step 1. Block the stomach on the left or the liver on the right for the entire course. Step 2. Add an electron patch field of about 153 centigrade per day to cover the pleural space hiding under those blocks.
Step 3, shield the spinal cord after 41.4 gray. And Step 4, for left-sided cases, you literally have to shield the heart after 19.8 gray. Don't miss these.
Okay, time for a little radiation oncology myth-busting. For years, residents were taught to universally irradiate surgical and chest drain tracts to prevent painful malignant tumor seeding along the chest wall. It was just baked right into early guidelines. But the important question we have to ask as evidence-based practitioners is, does the modern data actually support doing this?
Well, the definitive answer is no. The SMART trial in 2016 and the Bayman trial in 2019 prove there is absolutely no benefit to this practice. There was zero difference in the rate of tract metastases, overall survival, or chest wall pain between those who got prophylactic radiation and those who were just observed. So, the takeaway? Prophylactic tract radiation should no longer be your standard of care. Full stop.
Moving on to Section 4, limited-stage small cell lung cancer, and the infamous fractionation debates. There is a really fascinating divergence in survival outcomes to look at here. The classic INT0096 trial established 45 gray twice daily, or BID, as the absolute gold standard, yielding a 26% 5-year overall survival. Years later, the massive CONVERT trial came along, attempting to show that a higher dose of 66 gray given once daily could be just as good if not better. But it failed to prove superiority over the twice-daily arm. Because of that, 45 gray BID remains a highly recommended standard of care.
Now, an incredible clinical pearl regarding radiobiology can be found right here in the NCCTG trial. They tried to reproduce that BID benefit, but they used a split-course regimen that had a built-in 2-week treatment break. And guess what happened? That break allowed for accelerated tumor repopulation, which entirely negated the twice-daily survival benefit. It resulted in virtually identical outcomes to the once-daily arm. This is exactly why you never forget the danger of treatment breaks in fast-proliferating tumors like small cell.
Bringing limited-stage small cell into the modern immunotherapy era, we've got the brand-new Adriatic trial. For patients who complete concurrent chemoradiation without progressing, this trial achieved an astounding 55.9-month median overall survival using consolidation durvalumab. Compare that to 33.4 months with a placebo. Honestly, this is a massive paradigm shift, and you absolutely need to be ready to discuss it in clinic.
Finally, Section 5, Extensive Stage MPCI. Let's look at some shifting paradigms.
For extensive stage disease, you absolutely have to know the IMpower 133 and Caspian trials. They established immunotherapy, either atezolizumab or durvalumab, plus platinum etoposide as the new chemoimmunotherapy standard. Now, from a radiation perspective, you need to know the CREST trial. This study tells us to offer 30 gray and 10 fractions of consolidative thoracic radiation for patients who responded to initial systemic therapy, mainly because it significantly improved 2-year overall survival and intrathoracic control.
The timeline of prophylactic cranial irradiation, or PCI, is just a fascinating study in how better imaging completely changes our trial results. Look at the 2007 EORTC trial. It showed a great survival benefit for PCI, but they didn't require baseline brain MRIs, which means they were highly likely treating occult metastases. Fast forward to the 2017 Japanese trial. They mandated baseline MRIs to truly isolate prophylactic cases, and suddenly there was no overall survival benefit for PCI over careful MRI observation. Kinda wild, right? And you know, the debate doesn't even stop there. Even the specific technique of hippocampal avoidance PCI is debated today. If you do choose to offer PCI, should you avoid the hippocampus? Well, the Spanish PRIMER trial showed clear cognitive preservation when doing so. But on the flip side, the Dutch trial surprisingly showed no cognitive difference at all from standard PCI. It leaves us with a highly nuanced, really individualized decision to make with our patients. So I'll leave you with this provocative thought as we wrap up today's explainer. As our modern systemic immunotherapies get better at crossing the blood-brain barrier, and as high-res MRI surveillance becomes even more ubiquitous, will we just stop radiating prophylactic brains entirely? Or are we going to learn to hyper-personalize it using genomic markers? It really is the next great frontier in thoracic radiation oncology. Keep studying hard, use this explainer to anchor your knowledge, and we'll catch you next time.